So is my slide visible and moving?
Yeah, it is visible.
Thank
Visible.
you.
Full screen.
So
Good.
I've been
Please continue.
asked to talk about the dichotomy of insulin innovation and adoption. I think, it's a sponsored meeting, so there's financial disclosure for the honorarium that I would receive. Now, things have evolved. I'm sure everybody who's sitting here is no longer using an old Nokia phone that we all knew, and things have evolved for the benefit of human. And similarly, the insulin has evolved from venting and best the isolation of insulin to the modern first generation, then the second generation insulin like deglutec, like a basal insulin that has been there, which causes lower variability and has got a longer half-life, giving flexibility of meal regimens to our patients that is needed. Sorry, why is this like? Similarly, for premix insulin, it has evolved from ultra pure to biphasic human insulin to Lispro to biphasic insulin aspart towards to the crown presently, which is co-formulation, which has beautifully been explained by dear friend Shalini already. And similarly has devices. Long gone are those glass pens with the insulin, and now we've got beautiful pens which are user friendly and pumps which has made life for our patients far more easier. And we continue to strive to get better and better to provide the better avenues for our patients, because friends, we cannot cure diabetes. Our job as a clinician is to provide them a quality of life that they truly deserve. Now, if you look at the flexibility and inconvenience, the deglutec gives you a flexibility of 8 to 40 hours. Not that we'll ask the patient to take it like that, but then if it has that area of flexibility just in case sometimes due to various reasons the patient may not be able to take it. And ITEC has been very nicely explained how it has changed. Now, diabetes prevalence is increasing worldwide. I think it's an epidemic that is coming, and what we are looking at is only the tip of the epidemic, because a huge proportionate of patients could be pre-diabetic at to 15.3% with the ICMR India DEP study was this. And all the trials, all the studies have shown that a large proportion of our patients are not well controlled in diabetes. And this is very important, because if you're not going to control diabetes, the risk of complications goes high. It's very simple. What I tell my patients is that whenever there is a spike of sugar, it goes and slaps the various end organs. It will slap your eyes, it will slap your kidneys, it will slap your heart, it will slap your nerves. And there's a given point of time that you can take the slapping before that organ does not function. And so it's very important that we do not let that damage happen to our end organs. And hence, we need to bring the glycemia under control. But there's a fear when we talk about insulin. And in our current trend, if you see a huge proportion of patients are not controlled because insulin therapy is delayed for these patients. Now, the landmark trial has very clearly said that if you have 3 oral medication, even if you try to put a 4th one, it's not going to help. But there is a huge barrier that are there, both from the physicians and the patient's perspective, which actually is a burden for starting insulin therapy. They all wish for the golden duck, that is, everything gets honky-ponky clear without insulin therapy. But my friends, a lot of that is not possible. And even that, a lot of patients, even though they are insulin, omit a few doses that they are to their convenience. As I've explained, there's a risk of micro and macrovascular complications, which tend to increase, be it retinopathy, be neuropathy, be cardiovascular disease, be nephropathy, with poor diabetes control. Now, what are these barriers? These barriers, I would say, either they are physician-related barriers and are patient-related barriers. You see, depend upon your workload. If you're aiming to see 40 patients in a daytime, unless you have the ground staff and supporting staff for it, I don't think you're doing a good job for a patient. I was in England for 12 years. We saw 3 patients in an hour or 4 patients in an hour. And a lot of subtleties could come out which could give care of the patient. So you need to have time yourself or your team to give to the patient. And you need to have trained paramedical staff to support the patients. Because hypoglycemia is, anyways, patient has a barrier to start themselves on insulin. And if you have a hypoglycemic attack, you can imagine that patient is not going near an insulin pen ever in their life. Weight gain is a huge issue for a lot of our patients. And they worry that, yes, because their diabetes will get controlled, they will put on more weight. Everybody wants to be size 0 with all the ads and the movies that are going on. But what they fail to realize is that they're not leading a quality of life. And that's what we need to have a discussion with, honest discussion with the patient about the quality of life that are there. Now, even though we may have a lot of guidelines, I'm not a person who loves guidelines because guidelines, I personally think, are not for doctors. We look at a holistic approach for a patient. They may be for nurses who are doing specialist nurses, but we know what we are doing and we need to provide that care to our patients. And because targets get changed, newer therapies keep coming, and we need to keep the patients in the loop as what needs to be done. And we need to be honest to our patients. In fact, suppose your patient is coming to a clinic and you're going to talk about, you say, I'm going to give insulin. The patient's mind is completely blank. He's not thinking of anything else after that. His world has stopped when you utter the word insulin. And I'm sure all of us, including seniors, have more stories to say how the patients react when we, take out the word insulin. It's just, there are a lot of anecdotes everybody has to see, their stories, and everybody has strategies how to fight these barriers, because the barrier of the patient could be a knowledge barrier, socioeconomic barrier, which not really nowadays, because the cost of insulin has come down. Sometimes the cost of insulin is cheaper than the tablets. But psychological barrier is, I think, is the most important barrier that is there. Because diabetes, my friends, is not just a medical condition. It's a social, medical, familial condition. What you believe about diabetes, what your barber was telling you when you were having a haircut, telling that, once somebody had insulin, he died. That's, it fit in your mind, and you need to take that out. You need to understand his fears of insulin, and perhaps, strategies you need to find out to reduce their anxiety and help them focus on the broader picture of getting diabetes control and improving their quality of life. Sorry. One of the important strategies that we can do is that perhaps, if you inject the insulin, first dose of insulin in the clinic, and then talk to the patient, then, all the fear about the pain, the needle, everything is gone. And you need to give more consulting time and find an environment in which the patient can ask more questions and get their sides seen. Because lipohypertrophy is a real important problem that is there. And patients, because of faulty techniques of insulin, I do not let any pharma company teach insulin to my patients. I made that a rule in my clinic, and I suggest everybody does that. Either you do yourself or you train your staff to do it. Because that is the best way I found ahead, because the goals of everybody are different. Our goal is predominantly towards the patient and not towards the sale of the molecule. So lipohypertrophy should be examined every time, because this can be cosmetically distracting. This can reduce the insulin absorption and can also let patients to stop their insulin. So things have evolved. The newer insulins that have come down has got lesser weight gain, lesser hypoglycemia, and better quality of life. And we need to have workshops with our patients, and the insulin techniques should be checked at every visit that they come in the clinic. The most important thing out here that I should say is that बात कीजिए, बात करेंगे तो ही बात बनेगी. So start insulin conversation shortly after diagnosis, but you must have this open conversation with your patients. And together, we know that the future is bright. We know newer things are coming in the pipeline. You've got once weekly insulin coming. You've got oral insulin, glucose-sensitive insulin, and beta cell replacement. Hopefully, I shall see that, in the term of my life, that my patient will have beta cell replacement very easily. And that would be the love of every endocrinologist and diabetologist of our country and of our world. With that, I thank you very much for your pleasant, giving me the time to say. And in summary, I would say poor diabetes control increases the risk of micro and macrovascular complications. Newer insulins are there, which are convenient, but we need to have conversations with our patients, understand their anxieties, and develop strategies to help them cope and actually take insulin to get their sugar under control. With that, I thank you again once very much.